Hello everyone. So in our last video we treated irritable bowel syndrome or irritable bowel diseases, and today we're going to treat inflammatory bowel disease. So we're also going to look at the difference between this inflammatory bowel disease and irritable bowel syndrome. So this inflammatory bowel disease, it is also a chronic gastrointestinal disorder, but it is classified as a chronic inflammatory condition, and it affects the gastrointestinal tract. And we have two types. So the two types are Crohn's disease and ulcerative colitis. So these two disorders, they are characterized by an abnormal immune response leading to inflammation and tissue damage. So inflammatory bowel disease is often associated with periods of remission and periods of exacerbation, and it significantly affects the patient's quality of life. So when we're looking at the background of this disease, so this inflammatory bowel disease is an autoimmune condition. So it occurs when the immune system attacks the body. So it is an autoimmune condition with complex pathogenesis involving genetic predisposition, environmental triggers, microbiota imbalance, and dysregulation of the immune system. So it differs from irritable bowel syndrome, which is a functional disorder without significant inflammation or structural or tissue damage. So when we're looking at the two types of inflammatory bowel disease, first we have Crohn's disease. So Crohn's disease basically affects any part of the gastrointestinal tract from the mouth to the anus, and is characterized by transmural inflammation. That is inflammation involving all layers of the bowel wall. So it can cause patchy, discontinuous lesions, and it has common complications like causing fistulas or perianal disease. Then when we're looking at ulcerative colitis, so this ulcerative colitis, it affects only the colon and the rectum. So unlike this Crohn's disease that affects any part of the gastrointestinal tract from the mouth to the anus, this ulcerative colitis particularly only affects the colon and the rectum, that is the large intestine. So inflammation is confined to the mucosa and the submucosal layers, and is characterized by continuous lesions starting from the rectum and extending proximally. So there's higher risk of colorectal cancer when you have this condition compared to when you have Crohn's disease. So when we're looking at the signs and symptoms of inflammatory bowel disease, it's basically almost similar to the symptoms you see in irritable bowel disease, but you just see some differences. Like there will be presence of diarrhea, sometimes often bloody in cases with ulcerative colitis. Abdominal pain will be present too. There will be urgency to always use the restroom. Then you see rectal bleeding, weight loss. These are just the gastrointestinal symptoms that I would see. Then systemic symptoms like fatigue, there will be fever, night sweats, anorexia. Then when we are looking at extra intestinal manifestations, like manifestations outside of the intestinal system, like there would be arthritis. Then osteoporosis can also occur. So this, when we're looking at the clinical presentation of inflammatory bowel disease, it usually presents with alternating periods of remission and flare-ups. So there will be periods where the condition will not cause so much like the symptoms will not be so aggravated, and then there will be periods where it's just too much for the patient. So it has its different periods basically. So the severity may vary, and we can see mild cases where we see intermittent diarrhea, mild cramping, and there won't be any weight loss. Then we can also see moderate cases, like when the diarrhea becomes worse, like having frequent trips to the toilet, weight loss, anemia, and some other mild systemic symptoms. Then in severe cases, we can see the persistent diarrhea with severe bleeding, significant weight loss, and systemic complications too. So for the etiology of this condition, before we go into the etiology, I forgot to mention inflammatory bowel disease is believed to have both genetic and environmental influences. So is most commonly seen in developed countries, particularly in the North America and Europe, because there they have a variety of environmental factors, a variety of diets, so a variety of a lot of things that could just cause this inflammation. So, and the condition primarily affects young adults, specifically young adults between the ages of 15 to 35. So these are the people that commonly have this condition, a set of people that commonly have this condition. Then I've also talked about the signs and symptoms. So the like I said, the diarrhea is often accompanied by blood or mucus. And then when it comes to the abdominal pain, it usually occurs in the lower abdomen, or it occurs throughout the digestive tract. Then the weight loss, it could be due to malabsorption, or it could be due to reduced appetite. So this chronic inflammation, and accompanied with lack of appetite or reduced appetite and nutrient deficiencies, it can also contribute to the exhaustion. That's why we also see fatigue as part of the signs and symptoms. So like I said, rectal bleeding is more common with ulcerative colitis than with the other disease. And for the urgencies to defecate, that is also there, which is another thing in common with irritable bowel disease. And there will also be feeling of incomplete evacuation. So like I said before, when we're looking at the etiology, so the exact cause of this inflammatory bowel disease is not fully understood, but is believed to result from a combination of genetic, immune, and environmental factors. So the immune system mistakenly attacks the gastrointestinal tract, is mistakenly, and it leads to chronic inflammation. So the potential contributing factor is for example, we have genetic predisposition, that is the individuals with a family history of inflammatory bowel disease have a higher risk of getting it. And then dysregulation with the immune response, so an abnormal immune reaction to gut bacteria causes excessive inflammation. Environmental triggers like such as diets, like I spoke about before, diet, smoking, infections, and stress may contribute to disease onset and flare-ups. Because there was one video I watched where a girl, she specifically said that she was living a normal life, and then she went to the beach. All of a sudden, after eating, I don't know what she ate when she went to the beach, but she said after eating something at the beach, that is when she now had this that is when this her ulcerative colitis started. So basically what she ate triggered this condition to start, and I think she was living in America. So that is what I mean by having environmental triggers. Like in her own case now, it was part of her diet. So what she ate led to the disease onset, and now is like she's battling it for life. So environmental triggers are a cause, and then gut microbiota imbalance. So alterations in the normal gut bacteria may play a role in this disease development. So risk factors. So several risk factors increase the likelihood of developing this inflammatory bowel disease. For example, like I said, family history. So a significant risk factor, individuals with a first degree relative, and with a first degree relative whereby this relative has this inflammatory bowel disease, is at increased risk. Then age too. So most cases are diagnosed before the age of 35, so 15 to 35, this age range. Then ethnicity too. So it's more common in Caucasians and individuals of the Jewish descent. Then smoking too is a risk factor, because it increases the risk of having Crohn's disease. But this smoking can also have a protective effect in ulcerative colitis. So it has its pros and cons, but at the end of the day, smoking is not good. Even if it protects you from having against one condition compared to the other, it's not good in any case. Then we have dietary factors, like eating high fat and processed foods may increase susceptibility. Then using of NSAIDs, non-steroidal anti-inflammatory drugs, may worsen the symptoms because they increase acid secretion, they cause gastrointestinal bleeding, so if you're already having this condition and you are taking NSAIDs and you are taking it excessively, you are just not even helping yourself. So when we're looking at the anatomy and physiology of this inflammatory bowel disease, the gastrointestinal tract, it consists of the mouth, the esophagus, the stomach, and the small intestine, and the large intestine, and then the rectum. So inflammatory bowel disease primarily affects the intestines. So in ulcerative colitis, it affects the colon and the rectum, with continuous inflammation starting from the rectum and extending proximally. Then for Crohn's disease, it can affect any part of the gastrointestinal tract from the mouth to the anus, but most commonly it affects the terminal ileum. That is the that is a part of the small intestine, and it affects the colon. So it causes patchy transmural inflammation that can penetrate deeper layers of the intestinal wall. So this is basically the anatomy and the physiology of these two conditions. So when we're looking at the pathophysiology, so the immune system plays a critical role in the development of inflammatory bowel disease, and in genetically susceptible individuals, an abnormal immune response is triggered by environmental factors, which leads to excessive activation of inflammatory pathways. So key mechanisms include like activation of the immune cells, activation of these macrophages, T cells, and cytokines, such as the tumor necrosis factor alpha, usually drives this inflammation. And then we'll see loss of mucosal barrier function. So it leads to increased gut permeability, allowing bacteria invasion and further immune activation. Then this will in turn lead to chronic inflammation, which results in tissue damage, ulceration, and fibrosis, leading to obstruction. So in the pathophysiology, we have the activation of the immune cells, the loss of the mucosal barrier function, and then finally this chronic inflammation. So for the diagnosis of IBD is based on clinical evaluation, laboratory tests, imaging, and endoscopic findings. So some diagnostic tests could include like blood tests to check for anemia, which is a symptom, to check for anemia, and elevated inflammatory markers like C-reactive proteins and erythrocyte sedimentation rates. So use this blood test to check for inflammatory markers and also check for nutritional deficiencies. Then stool tests to detect the fecal calprotectin, which is also a marker of inflammation, and we can also use this to rule out infections. Then colonoscopy and biopsy, so they are usually essential for confirming the diagnosis, and it usually shows mucosal inflammation and ulceration. Then when it comes to using imaging studies now, so magnetic resonance enterography or computed tomography enterography, that is CT scan, can assess disease extent and complications. So this is where imaging plays a significant role in the diagnosis. Then when we are looking at differential diagnosis, like I said before, differential diagnosis basically means like conditions that mimic the same mimic the inflammatory bowel disease, like mimic symptoms. Like I spoke about in the last video, irritable bowel syndrome is part of this differential diagnosis, and but in this case we have functional gastrointestinal disorder without inflammation. Then we also have infectious colitis too, like infectious colitis that could occur from bacteria, virus, or parasites, which also cause similar symptoms. Then celiac disease, which is also an autoimmune reaction to gluten, causing intestinal damage. Then colorectal cancer too, it can also present with weight loss, rectal bleeding, and changes in the bowel habits. So these are basically the other conditions that could mimic the this inflammatory bowel disease. So we often do diagnostic tests to rule them out from what we are majorly looking for. Then for the management, and the approach considerations, so the management usually depends on the type, the severity, and the complication of the disease. So treatment goals, they include the first, reducing the inflammation, relieving the symptoms, and preventing complications. So when we're looking at reducing the inflammation now, so for the medications that we can use in this case, like aminosalicylates like mesalamine, it can be used in cases of ulcerative colitis to reduce the inflammation. Then steroids, to corticosteroids like prednisone, budesonide, it can be used for short-term control of flare-ups. And for immune suppression, since this is an autoimmune condition, we can use immunomodulators like azathioprine, methotrexate. So we can use them to suppress the immune system to prevent relapse. Then we can also use biologic agents like infliximab to target specific inflammatory pathways. Then antibiotics too, because sometimes they are used for Crohn's disease to control the bacterial overgrowth that could occur in this condition. Then in severe cases, surgery may be required, particularly in ulcerative colitis, where the total colectomy can be curative. So Crohn's disease patients may require the resection of the diseased bowel segments. So this surgery is mostly used in severe cases where the tissue damage is really bad. So there could also be lifestyle changes like dietary modifications. So having low residue or elemental diets may help to reduce flare-ups or during the flare-ups. Then lifestyle changes like smoking cessation, like reducing, if you're not even reducing, stop. If you are someone that smokes and you have this condition, just stop smoking. Then management of stress too, and also exercise may help to control symptoms. It won't significantly help to treat, just control the symptoms, and it could be helpful when you take these steps together with the medications that you'll be using for this condition. So for the prognosis of this inflammatory bowel disease, so this disease, it is a chronic condition and has periods of remission and relapse, and early and appropriate treatments can help to manage symptoms and improve quality of life. So however, in complications such as having strictures or fistulas, malnutrition, and increased risk of colorectal cancer, so these complications, they may occur if like the treatment is not done properly. So these are just the complications that may occur. And like I said before, I would also try to explain the differences between the inflammatory bowel disease and irritable bowel syndrome. So basically, the difference is that inflammatory bowel disease is a chronic inflammatory disease, and this irritable bowel syndrome is a functional gastrointestinal disorder with no detectable inflammation or structural damage. But we will see structural damage with inflammatory bowel disease, and it is diagnosed for irritable bowel syndrome is diagnosed based on the symptoms. We can diagnose it alone based on the symptoms. Then for inflammatory bowel disease, we can't just diagnose it alone based on the symptoms. It's diagnosed based on endoscopic findings and biopsies, because it is a more how do I put it? It's a more serious condition. And then when we are using the symptoms to compare, inflammatory bowel disease, you will see bloody diarrhea, you will see weight loss, you will see fever, and you see complications like fistulas. But in irritable bowel syndrome, you just see abdominal pain, bloating, altered bowel habits with no serious complications like you have in inflammatory bowel disease. And then for treatment too, they both have different treatments. So it's inflammatory bowel disease, it usually requires anti-inflammatory drugs and immunosuppressive therapy, whereas irritable bowel syndrome does not require any of this. It's usually managed with dietary changes, stress reduction, and symptom control medicines like anti-diarrhea medicines for the pain, like I explained in the last video. So this is basically the difference between these two conditions, inflammatory bowel disease and irritable bowel syndrome. Thank you.